Welcome, Dr. Jackson.
Great. Thanks for having me.
So talk to us a little bit about what fungi is in general. How are dangerous ones different from the mushrooms that we eat?
Well, that's a tall order to talk about fungi in general. There's millions of fungi out there, as many as 5 million different species, most of which have never been discovered. And they range dramatically from the mushrooms that you can see, that you eat, to microscopic fungi like Candida auris that we'll talk about today that are microscopic. And I think that's just remarkable to me, that how many fungi there are and how understudied they've been. They once were thought to be basically a lower form of plants. You know, in the older texts and everything, there really was very little attention paid to fungi, and we learn more and more about how critical they are to our ecosystems, to crops and trees and their communication with roots and mycorrhizal fungi. But when we're talking about the dangerous fungi, the ones that cause human infections, there's really fall into 3 different categories. There's the molds. So, you think of bread molds and the like. There's only a few types of molds that actually cause those infections. There's the yeasts. People have heard of yeast infections. That's like Candida. Candida isn't one of the major types of yeast, but there are others. And then they call dimorphic fungi, meaning they exist in a mold at one temperature and then in a yeast in our body temperature. And a yeast just means it's like a single cell, almost like a bacterium, but just much, much bigger. And so out of these millions of fungi that are estimated to exist, only about 300 or so cause human infections.
300 is still a lot.
It is, and unfortunately that number grows each year.
As we discover more.
Right.
What is the Candida auris fungus and where did it come from? You already said it was a microorganism, but elaborate.
Candida auris is similar in many ways to the Candida that we know well, that live on our bodies all the time. Candida albicans lives in and on our bodies all the time. It's the most common cause of oral thrush, oral yeast infections, vaginal yeast infections. And there are lots of other Candida species. And so Candida auris is one of them. It's a microscopic fungus. But the difference with Candida auris is that it's very different from all the other Candidas that we're used to. There's over 500 different Candida species, and that number grows each year as scientists discover more and more. Candida auris was only described just 10 years ago in 2009. Now, we know we have isolates. We've seen isolates that go back to the mid-90s in a couple locations. But really what we've seen is this fungus has been detected all over the world now just in the last 5 to 10 years. Where did it come from is a huge question. There was a lot of news coverage this summer about an article suggesting it may be linked to climate change. We've published another article called On the Origins of a Species, speculating on what might lead to the rise of Candida auris. And there's still a lot of debate. I mean, really, the amazing thing is it's never been found in the natural environment. It's only been found in association with humans, probably because we haven't been culturing the natural environment. The world is full of yeast out there living on plants and flowers and fish and all these types of creatures, and yet very little of that has been described, particularly in tropical environments. And when you look at closely related species to Candida auris, they tend to have been found in places like mangrove tree roots, plant flowers in South Asia, fish in the Caribbean, just found in a whole smattering of tropical environments. And so it doesn't mean that's necessarily where Candida auris came from, but it makes you think maybe it came from one of those areas. So anyway, this is a really important thing that we're hoping that more scientists study to try and understand where it came from.
That's amazing. Is this the same fungus that killed people after the Joplin, Missouri tornado?
Candida auris is a very different fungus than the one that caused those horrific infections after the tornado. Those were caused by mucor or mucormycetes. They're a type of mold infection, basically, that live out in the environment, and they have these awful, like, penetrating injuries from the debris from the tornado that introduced that mold. That's very different from Candida auris. Candida auris tends to get on our bodies, live on our skin, and then when we become sick for some reason or we have an invasive procedure, that's when it can get in and cause infection. So they're completely different and unrelated to one another.
But mold is a fungi.
Yeah, mold just means that it's multicellular, more than one cell. It kind of branches out in these hyphae that travel, and yeasts. Candida is a yeast. They are generally single cell little creatures.
Your article says that most Candida infections are commensal. Tell us what that means.
Candida infections are thought to be the classical teaching has been that Candida infections are commensal, meaning that Candida live on our bodies, and they live in our bodies, in our guts. So we think of the microbiome in our intestines, predominantly of bacteria, but there are quite a number of fungi in there as well, including Candida species. And so what's thought to happen mostly is that people get in the hospital, they have antibiotics which kill off the bacteria, it allows the fungi to grow, they have abdominal surgery, they have other conditions that basically help the bacteria either move from the gut into the internal organs or the bloodstream, or that move from the skin to the bloodstream type of thing. And so that's why we think of Candida infections really coming from our own microbes that are living on our bodies for the most part. That's what makes Candida auris different, because we're seeing this spread between patients in healthcare facilities. This is not something we usually see with other Candida species. There are outbreaks that have been rarely reported, but this is really something new for Candida.
Yikes. Okay, well, I think you've said a lot of reasons why we should be concerned about this fungus. Is there anything you want to add to that?
Absolutely. I think there's a couple key reasons that we're concerned about this fungus. I think the first I already mentioned is that it spreads within healthcare facilities in a way that we have never seen before. It acts more like a bacterium than a fungus in some ways. Number two is that it's highly drug resistant most of the time. There's only 3 classes of antifungals out there, as opposed to well over a dozen classes of antibiotics to treat bacterial infections. And this fungus is often resistant to 1, frequently resistant to 2, and occasionally resistant to all 3 of those classes. Again, something that we've never seen before in a fungal infection like this. I would say the third major concern is that it's often resistant to disinfectants used in healthcare facilities. So the commonly used disinfectants are often quaternary ammonium compounds, or quats as they're called for short, and many of those don't work against Candida auris. And so for that reason, we recommend higher level disinfectants to wipe out Candida auris. And the fifth, we may talk about later, is about misidentification. And that happened in this instance in Colombia, where the common yeast identification systems at the time were not able to pick up Candida auris and differentiate it from other species.
All right. So what are these higher level disinfectants you're talking about?
Now, these are disinfectants that are generally available in many healthcare facilities. There's actually now a specific claim by the EPA, the Environmental Protection Agency, that certain disinfectants can be registered to be shown that they work against Candida auris. But until this claim was about, we just recommended that healthcare facilities use disinfectants that work against C. diff, Clostridioides difficile. And most healthcare facilities will have those. They tend to involve things like bleach, but also hydrogen peroxide. Each product is a little bit different. But those disinfectants are usually just fine at getting rid of Candida auris. But that said, environmental cleaning is so important when it comes to this. And you miss a spot, or there's just or someone thinks they're responsible for cleaning one thing, and someone else thinks somebody else is responsible for cleaning a certain piece of equipment. Anyway, there's a lot of challenges that go for environmental disinfection, and that's an absolutely key way to control its spread in healthcare facilities.
Yes, I know how difficult it is to even often get doctors to wash their hands, so I can imagine that this is quite the challenge. Okay, so 2 and a partial third antifungal medicines don't work. What do people do if they get an infection? What's done for them? It's
a really good question, and it's one that we've been struggling with. I think the one important thing to know is that there can be a lot of variability in the resistance depending on the strain. And so some strains tend to be much more susceptible to antifungals than others, and there's some, again, that are resistant to all 3. Generally, one class called the echinocandins tends to work for most Candida auris infections, thankfully, at this point, and that's why it's recommended for first-line therapy. But if that one is shown to be resistant, sometimes people will try a variety of things. They may try higher doses. They may try a combination therapy at the hopes that there's some synergistic activity. But that's a major concern, and that's why we're at least optimistic that there are antifungal drugs, new ones in the development pipeline that show some promise against Candida auris.
Oh, okay, that's good to know. You touched on this briefly, but in the case of this fungus, what's the difference between an infection in the digestive tract and the one in the skin or blood?
Most common Candida infections involve the skin, so places like or the mucous membranes, like the mouth or the vagina or those types of areas. Candida does live in our digestive tract. It very rarely causes infections of the GI tract. But what we worry about is when it actually gets into the bloodstream, or it gets into those internal organs like the kidney or the liver or the spleen or those types of areas. And so the Candida infections that affect like our mouth and vaginas, those are just very common in just about anybody. But these invasive infections, these ones that get into the bloodstream, tend to affect people with either weakened immune systems or having a bunch of medical procedures.
Okay, so those are the ones that you really need the antifungals to work on.
You may need the antifungals for the other ones too, but you really, really need it. It's true. It's life-threatening to have an invasive infection, so you absolutely need it for those.
Who's most vulnerable to this type of infection?
Well, the classic teaching for Candida is that it's people who have a weakened immune system, for instance, from cancer or a transplant, people who've had abdominal surgery, people who've got sometimes diabetes or central venous catheters, basically a large IV that goes into one of the very large veins in our body. What's interesting about Candida auris is it does affect those people, but it seems to affect sort of a wider group and people. Those invasive devices really seem to be a key factor in predisposing people to getting in these infections.
So, are there specific disinfectants for those apparatus different than cleaning the floor, or?
That's a great question. It's always a difficult thing when it comes to cleaning equipment because some of our strongest disinfectants, like those that include bleach, can be pretty corrosive, and you really can't use those on sensitive medical equipment. And so, there's a whole lot of different strategies people have to use to be able to clean those more specialized devices. Because
there's been some outbreaks. I don't know if they're of Candida auris, but of other molds or fungus, and a couple of years ago in spinal blocks and
the contaminated steroids
and stuff. Yeah.
Right. There was a big outbreak back in 2012 related to contaminated steroid injections that were going into people's spines for pain relief. And the issue in that case was actually that facility that was compounding the steroid medication that was injected had really poor handling practices, and so that allowed the steroids to get contaminated from there.
Okay, that's frightening. Your article is about Candida auris outbreak in 4 Colombian hospitals in 2016. Tell us about those outbreaks.
Sure, and I want to emphasize that we did this as a joint investigation with the Colombian National Institute of Health, the Instituto Nacional de Salud, or INS, and they really invited us to come down there and work with them to try and figure out what was going on. But I want to just take a second and set the stage about Candida auris in 2016. It was really still a pretty much unknown pathogen at that time. There had been a few publications out there sort of describing cases and a few small outbreaks in areas. And we really got concerned when we started hearing in 2016 about multiple hospitals around the world seeing these very concerning outbreaks with this spread between patients and characteristics that we'd not seen before. And so we put out a call for letting an alert to clinicians in the U.S. to let them know to be on the lookout for it. And we also started talking with our international partners about this issue. And that's when Colombia reached out to us and said, hey, we've got these cases of Candida hemolonii. And you may be asking, what in the world is Candida hemolonii? And so did we. The issue is it's another rare species of Candida, but when I talked about that misidentification issue, a lot of the yeast identification systems will misidentify Candida auris as Candida hemolonii. And so when all of a sudden a couple hospitals started to have a bunch of Candida hemolonii infections, they sent those isolates, those specimens, to us at CDC, and the lab here tested them and found out, actually, lo and behold, they were Candida auris. And so once that was found out, we worked together with the Colombian National Institute of Health to really investigate what was going on with these hospitals here. So that's where things stood in 2016, when we were first learning about these Candida auris confirmed cases in Colombia.
Would the treatment have been different? I mean, did it matter that it wasn't hemoli?
I think the key difference is that Candida hemolonii generally does not cause invasive infections. It doesn't grow at our body temperatures. And I think the major thing was that it was different from all the other Candida species that had come before. It was something new in that area. And the reason we were trying to jump on this is we'd already seen in some other places, including places like India, where it started out as a small thing and pretty soon grew to be the dominant infection in those hospitals. And unfortunately, we've now seen that in a number of places around the world, including in South Africa, where it's now become one of the leading causes of these invasive Candida infections. And so the problem is, not only does it just push out some of the other Candida species, it's actually additive on top of that. And you then have resistant infections in place of in place of the susceptible ones that you had before.
Okay. So is this only found in hospitals and care facilities, and why are these places more susceptible? Is it because of the difficulty in cleaning that you were talking about, or more than that?
I think there's still a lot of unanswered questions, but when we look at the known cases that have all been diagnosed, essentially all of them come from healthcare facilities and people who've had, again, sort of intensive medical procedures or the like. I think it's possible that it's out there circulating in the community to some extent, but we think that's probably much likely because most of the transmission pathways that we've seen tend to involve either hospitals or long-term care facilities, sort of high-level long-term care facilities. And I think there seems to be something different about patients' skin once they've sort of been sick and in the hospital for that long that really allows Candida auris to kind of set up shop and thrive in a way that doesn't happen if you're sort of out and about and able to bathe and do your normal activities kind of thing.
This is sort of a weird question, but do you think sweating helps get rid of these things?
I think it's an unanswered question. It's hard. I couldn't tell you.
Because I don't imagine when you're in a hospital bed you perspire much.
There may be something for being out in the sunshine and the UV light that might help kind of bring it down too. I think there's a whole microbiome to our skin that we're just only beginning to understand.
Okay, so go on. Tell us about your study specifically. What did you go into it looking for?
So we went down with a couple different ideas in mind, but the main thing was just to figure out what is going on. So, in the steps of an outbreak investigation, one of the first things is perform the descriptive epidemiology, and that just means characterize the cases. Who are they? What were their conditions? What was going on with them? Because there's a lot that you can learn once you have that initial information about what the transmission might be like and what the control measures are like. So, these joint teams went down to these 4 different hospitals, 2 in the northern part of Colombia and 2 in Bogota, and basically just it did intensive chart reviews on each patient and just looked at what were the procedures that they had, what were the medications, what were their characteristics, what were their age, all of those types. Did they survive? Did they die? All of those types of things. And what we found was that patients were generally quite ill. 100% had a central venous catheter, a central line, basically a large IV that goes into either the neck or the groin. Many had been intubated, which means they had a breathing tube put down, and a large proportion had surgery. So anyway, there was a very sick population. One of the things that came up though was that a surprising proportion were in children. Around a third or so, and even a sizable number were in infants as well. Generally, these were children that already had many other medical issues to begin with. But I will say this is different than what we've seen in the United States, where essentially nearly all the cases have been in adults. And I think what that reflects is really where Candida auris has been circulating. And this is why it's so important that we continue to try and contain it and keep it out of other facilities. Because once it gets into a facility, start spreading, it can affect whichever patient is there that has sort of the right risk factors, no matter their age.
Okay, so how is your study different from a few others that have been published on this particular fungus and even in EID journal?
Yeah, I think this is just one more piece of the puzzle to try and understand what's going on with Candida auris. It's similar to what's been done in other places as well, but I think it's important to understand that there's different strains. So there's actually 4 different strains, now maybe 5 different strains, as recently published in EID, of Candida auris. This is sort of known as the South American strain, although we don't really know that it originated there. But it was first detected in Venezuela, up in the northern city of Maracaibo. What's interesting is that these cases in Colombia were first identified in a North Coast city not all that far from Maracaibo as well. So whether there's a relationship or not, we don't know. It's also important that there's major differences in healthcare and patient populations around the world. And understanding how Candida auris was behaving with this strain in this population is important for its control. And the other is, this was one of the first sort of field studies that we did with Candida auris, and I think this actually helped shape both the response in Colombia and the response in the U.S. It informed a lot of what we knew about what to expect with Candida auris.
You said that a lot of the patients in Colombia were small children and even infants. In your study, you say 30% of the patients were less than a year old. Do you have any more to say about that?
I think it's a concern for in the United States as well, that we just really want to keep this yeast out of pediatric intensive care units and neonatal nurseries. I think that was the issue in Colombia, is that it had just gotten into one of these units and had sort of set up shop and was causing infections in infants. So I don't know that there's any major biological difference. I think it's just a matter of where this fungus ended up.
The spots that didn't get cleaned. What were the outcomes for these patients? Were they okay in the end?
Unfortunately, over half ended up dying while in the hospital, and I think it was about 40 or 43% died within 30 days. So I think the big caveat to that is we don't know if they died from Candida auris or from one of their many other medical conditions. Probably this is true with any form of invasive Candida infection. There's probably some percentage for Candida in general. It's thought maybe 10 or 15% of people die from their Candida infection. I think just one other thing I want to point out about that is the median time from culture to death in these patients was about a week. So it suggests that, given that there was 22 days on average about when patients came into the hospital, so when they were first diagnosed with Candida auris, and then there was only a week from Candida auris to death, suggests that Candida auris may have been playing a role in some of those deaths.
Okay, looking at all the data that you collected, what ultimately did you find? Was there anything that surprised you?
Given how early we were in our understanding of Candida auris at this point, I think I was surprised, at least personally, about how sick these patients were, about how many comorbidities they had, about how many had a central line, how many were on a ventilator, and all of those types of things. So I think that it did help underscore that Candida auris was affecting the sickest of the sick, our most vulnerable patients, and sort of showing why it's so important, given the mortality rate, that we try and contain it.
Okay, so your article says the armpit and groin were the most commonly colonized sites. Why do you think this was?
Again, this is another mystery of Candida auris. Why does it seem to colonize the skin more than other yeast species or Candida species, at least? We're not sure, but this is a finding that's been consistent across different areas in the world. The armpit and groin just seem to be places that this fungus likes to hang out. It probably also likes to hang out in the nose and a few other places as well. I should say that in this investigation, there were only, I think, 5 patients in which we cultured Candida auris from various body sites. 4 of them had it in either the armpit or groin. But that helped, this plus other information helped guide our response in the United States, where now when we're looking for colonization within a healthcare facility, we actually do, some people call it a Zorro swab, where you kind of go like a Z, both armpits and then both sides of the groin to look for colonization. And the idea is that single swab is sort of a cost-effective and more rapid way to look for colonization than trying to culture a whole bunch of different body sites with different swabs and lots of testing.
Oh, I see. So instead of 4 swabs, you have just one that's collecting from 4 sites.
Right.
Okay, so going forward, what can hospitals do to help prevent or control this infection?
Great question. So there are several key things that are needed. And the good news is most of these interventions are the same as just classic infection control that work for most germs. So hand hygiene. You mentioned how difficult that is in general, but it's just critical for the control of Candida auris. Those alcohol-based hand rubs work just fine for Candida auris. People use them far more often than they do soap and water. Soap and water is hard to use all the time, so that's a key thing to making sure your hand hygiene rates are really good. Number 2, the environmental disinfection that we talked about, using a product that's effective against Candida auris, and we need more research on what other disinfectants are effective against Candida auris. Number 3 are sort of your classic infection control procedures. So trying to put patients in a single room if you can, using gowns and gloves, cohorting staff or patients if they've got it, meaning putting them together so they are less likely to spread it to others. And then another is working with your health department, since they are really key in sort of helping control the spread of these sort of multi-drug resistant organisms. And then the last is communicating when you're transferring a patient from one facility to another, so that receiving facility knows, hey, this patient is colonized with Candida auris, and they can take the right precautions to protect the rest of their patients as well. Okay,
I was thinking about gloves just yesterday, and you just mentioned them. So if doctors or janitorial staff or whoever use gloves, does that take the place of hand hygiene in other ways?
I think that's a common misconception that the gloves are no substitute at all for hand hygiene. It's really important that people are washing their hands or doing hand hygiene before they put on gloves, and then after they've removed their gloves as well, because there's a lot of ways to contaminate your hands before or after that. So they're definitely no substitute.
Okay, that's disconcerting. Thinking of all the doctors that just come in and put on gloves and take them off and go.
Well, they may be doing that hand hygiene right out in the hall, right as you leave. So let's hope that's the case.
What do you personally think is the most important aspect of this study?
I think the most important aspect of this study was really this investigation was really getting in there and understanding who was being affected at this early stage of the epidemic, finding out where the colonization was taking place on people's bodies, the fact that it was often in their axilla and groins, finding out the populations, and really from there working closely with the National Institute of Health in Colombia to put in place infection control recommendations. Because I think this investigation is more than just the data, but it's actually representative of this whole collaboration of improving infection control in these healthcare facilities and many others.
You work as a medical epidemiologist at CDC. Tell us what that means, what your job is, and also what you enjoy most about it.
So I work in the mycotic diseases branch, which is another word to say fungal, and I'm the team lead for epidemiology.
Are you a physician?
Yeah, and I'm an internal medicine trained physician and preventive medicine as well. And so I actually use that medical training all the time in our outbreak investigations, in our studies to understand the burden of disease and other research that we do about its epidemiology, which basically means how are diseases affecting people and why? What are those risk factors? And what I love about my specific position is that, there's just so much to do. I mean, I think that's the challenge is that fungi are so understudied, but it means that there's never a shortage of interesting questions to look at and important topics to deal with. I think the challenge with fungal diseases is when I tell people I work on fungal disease, I know they're immediately thinking about their toes. But and that's important. I don't mean to, because foot fungus is certainly a problem for people that deal with it. But I don't think people don't understand. The public often doesn't understand. There's a lot of invasive infections, severe infections that come from fungi, and I think that translates to sort of a lack of attention in the research community to some extent as well. And so, I think we're trying to do whatever we can to try and raise the profile of fungal diseases to make people understand this is a challenge. We've got new pathogens coming out. We're suppressing people's immune systems more and more because they're living longer with other conditions. And there's just a lot to be learned in this area. And I think the thing I love best about working where I do is the people. It's such a mission-driven culture where we're really focused on improving health for people. It's not about trying to accomplish this or that. It's really about what can we do to prevent illness and death.
How long have you been at CDC, and where were you before you came here?
I've been at CDC almost 10 years. I started out as an EIS officer, an epidemic intelligence service officer in the foodborne and waterborne disease group, where I worked on Guillain-Barré from Campylobacter infections and cholera and salmonella outbreaks and E. coli outbreaks and the like. And then I spent a couple of years working at a local health department, and then I spent some time working on listeria outbreaks, where I worked on outbreaks involving Bluebell, ice cream, and a couple other food producing companies.
I think that's one of the things that I find most fascinating when I talk to people, interview people at CDC. There's such a varied background of so many interesting things that you've done along the way before you came to where you are at this point, which is fascinating too.
It's interesting because people often say, how can you just jump from thing to thing like that? And I don't like to think of myself as jumping, but you can really get into a subject matter. But the epidemiology, the outbreak investigation skills, the partner relationship skills, all of that is sort of transferable to some extent. And I think we bring